I am Shalini Gulani, a medical student at the Aga Khan University and a part of the student organizing committee for the third Neuro-Oncology Symposium. I will be moderating this 15th session for this symposium. I would now like to introduce the chair for this panel discussion, Dr. Saqib Bakshi, and co-chair Dr. Hafiza Fatma. Dr. Saqib Bakshi is a senior instructor in the Department of Neurosurgery at the Aga Khan University. He is an FCPS in neurosurgery and has completed his MRCPS from the Royal College of Physicians and Surgeons of Glasgow. His interests lie in neuro-oncology, awake craniotomy, and epilepsy surgery. Dr. Hafiza Fatma is the chief resident of neurosurgery at Aga Khan University Hospital. She recently cleared her MRCPS in neurosurgery and is an active member of Pakistan Academy of Neurosurgery, Neurological Surgery. So without further ado, I would now like to hand over the stage to our chairs.
So good afternoon, everyone. So this panel discussion is for the development of surgical neuro-oncology as subspecialty in LMICs, and we'll discuss about the different challenges and how we can work through it.
So we would like to invite our panelists for this discussion. First of all, I would like to invite Professor Reed Thompson to please come to the stage. Professor Reed is here from United States, specifically to attend this conference and to further the collaborative efforts between Vanderbilt University and Aga Khan University. Next, I would like to request Dr. Ehsan Bari to please come to the stage. Dr. Ehsan Bari is Associate Professor of Neurosurgery at AKU, and he's also the Program Director for Neurological Surgery Residency Program at Aga Khan University. He did his FRCS from UK and then did his FCPS in neurosurgery as well, and has more than 20 years of clinical experience in neurosurgery in Pakistan. Next, I would like to invite Dr. Iram to please come to the stage. Dr. Iram is head of the Department of Neurosurgery at Jinnah Postgraduate Medical Center and is a consultant neurosurgeon over there as well. Next, I would like to invite Dr. Ahmed Gilani to join the panelists. Dr. Gilani is a neurohistopathologist and in fact the first neuropathologist to be present in Pakistan. He recently joined Aga Khan University, and we are really glad that he's here with us. Lastly, I would like to request Dr. Michael Devon to please come to the stage and join our panelists. Dr. Michael has a vast experience in global surgery and global neurosurgery. He had spent some time in Harvard University working with renowned faculty over there, including Dr. Key Park, and also spent significant time in sub-Saharan Africa and has first-hand experience of neurological surgery being performed in low-income and low-resource settings. So we are glad that we have a good combination of experience here in our panelists, and we'll start the discussion. We have worked out some basic points which we'll present before the panelists, and then we'd take feedback and points from each one of them.
So my first question is for Dr. Ehsan Bari. Sir, as you have worked in NHS, which is a resource-rich setup, and then coming to Pakistan and working in a resource-limited country, where you know that human as well as material resources are limited. So how do you see resources as a limiting factor for the development of surgical neuro-oncology as the subspecialty here?
Thank you very much, Hafsa. It's always difficult if you have constraints, especially the money constraints. In Pakistan, we have resource constraints and the money constraints. But naturally, the necessity is the mother of invention. You have to find ways, low cost values, the ways you all. Initially, when we came over here, frozen section was not available and all these things. So once these things were available, now with especially neuro-oncology, we need. The problem with us is that during tumor surgery in Pakistan is it's very costly. The real, if you do all the right thing, if you look at it before the surgery, you need a pre-op MRI scan, you need a post-op MRI scan, you do a neuronavigation MRI scans, frozen section, and nowadays, you need a per operative MRI scan. These MRI costs a lot. So what we started doing screening first, and then if there was something, then we would do a complete one. We do only one study in neuronavigation, so that way we saved money. And but now there are so many MRI scans available. It's much easier and cheaper to do MRI scans done in Pakistan than to get it done in America. So we would get it done in 5,000 rupees, which is $10. In America, it's probably $5,000.
So, Dr. Iram, you work in public sector. So what's your opinion on this? How do you see it as a limiting factor for this?
It's a totally different experience at a government setup hospital. And the main issue is that we need financial support. And we have the multimodality treatment facilities available at JPMC. As I'm working there, we have a tomotherapy, we have a cyber knife, and we have the separate MRI facilities as well as CT scan. And we are not charging any penny from the patients. But the main restriction is setting up a new unit and then needing a motivated team. And definitely it's a multidisciplinary approach. We need a radiologist as well as an oncologist and then a good anesthetist team. So it's a very difficult for us, especially when we don't have a money and we are getting it from different like Patient Aid Foundation, etc. So sometimes maintenance of the things, these facilities, that is MRI and cyber, it is already very difficult. And secondly, we are not only giving care to this cancer patient, we are also looking after these trauma patients and as well as with the benign disorders. So if we will restrict our residents and the one oncologist to this, then probably we'll be only dealing with these situations, because Jinnah postgraduate unit is one of the biggest tertiary care unit, and most of the patients are referred from all over the Sindh. So it's very difficult to set a different oncology unit, and because we have to look after other benign disorders as well. So these are the limitation. One is the cost, and then the other benign disorders which we have to look after, as well as the trauma. Thank you.
So, Dr. Reed, you have worked in Africa, and the condition is pretty much same as we have here. So what is your experience in working in a resource limited setup, and how do you see it further?
Thank you. Now it's on. Thank you. Sorry. Well, what was interesting to me is that over a several year time frame, traveling back to Tanzania, I saw the imaging availability made all the difference. So, for example, when we first started at this particular hospital, there was no CT scan, and so how do you, when we came back, there was a CT scan, and that was a significant, game changer. And so we're not even talking about MRIs, we're talking about CTs. There was an MRI in the town, but it was really difficult. I will say that it's also worth pointing out that there are even parts of the United States where you can't get a CT scan, and very rural areas in particular. You have to make a lot of triage decisions. One of the things I do hope that we can talk about is sort of the education opportunities, because what I saw in Tanzania were incredibly skilled young surgeons who were very adept at managing some of the very basic challenges. They could treat subdurals, they could fix shunts. They had a skill set that was very much equivalent to our fifth year residents, but they just did not have the techniques to treat brain tumors. And I don't think it would take much, because they had already had such a great foundation. But what they needed was experience. They needed, hands-on and some guidance there. So I hope we can talk about that too, because to me, it is also notable that you need, the infrastructure as far as the equipment, but you also need, the people who know how to, the judgment and the skill set, and also how best to partner with institutions and countries to elevate everyone with regard to their clinical skill set.
I
Thank you.
tend to agree with Dr. Reed because we need to have human capital first. We need to have trained people first. Once we have a trained people, they would find their way. We would get things because if we don't have the trained people, we don't have the human capital. The main thing we have to invest is in human capital, train our people. So once the people is there, there will always be some way we will get the patient done.
Thank you, Dr. Bari and Dr. Reed. So moving on, taking on this last comment of Dr. Bari. So I would like to ask Dr. Iram that when we talk about development of surgical neuro-oncology as a subspecialty, we know that world over, wherever neuro-oncology is practiced as a subspecialty, there are trained people present over there already, and they have their subspecialized practices, and not just for neuro-oncology, for other subspecialties as well. If you take the case of Pakistan, we have only one neuro-oncology fellowship program at AKU, which was started a few years back. And considering Pakistani population and the caseload, there are very few people who are trained to be surgical neuro-oncologists specifically. And it is also a significant constraint for us that to how to train such a larger number of neurosurgeons so that they could practice evidence-based and best neurosurgical practices with regards to neuro-oncology. So how do you think this this gap could be bridged in a shorter period of time?
Yes, a difficult situation because we are already having an extreme shortage of neurosurgeons in Pakistan. And definitely not only the neuro-oncology we have to look after other things as well. So we need a specialized unit as well as a dedicated team who wants to be restricted to this neuro-oncology instead of jumping from one field to another like benign disorders, etc. So we need a dedicated team. But for a dedicated team, we need a good setup. And and there in a private sector, except for Khan, I don't think that there are so many other hospitals which will be offering this with a good setup of neuro-oncology. So definitely, this is a need of the day. And last time I was while listening to one of the lecture, they gave this message that the most successful people are those that who plan the tomorrow from now onwards. So definitely, this is the need of the day for Pakistan, that we need a specialized neuro-oncology team. So we need to separate neuro-oncology as well as this trauma and benign disorders. But definitely a setup is required, and definitely. But this will take some time. I don't think so that will be possible in near future, especially in our setup. Probably at Aga Khan, and that's why the Aga Khan is the only institute that is offering the second subspecialty in neurosurgery. And although while in majority of the cases that reach to JPMC are already in advanced stage, so this is a time that a specialized unit should be created that should only be restricted to treating the patients with cancer. So thank you.
Thank you, Dr. Aram. So I would move on to Dr. Michael. And Dr. Michael, you have a vast experience of imparting training to neurosurgery registrars and trainees in sub-Saharan Africa. And of course, you have quite a vast experience in global neurosurgery as well. So how do you think this gap of having trained surgical neuro-oncologists be bridged in a shorter span of time? Because we know the ideal case would be to have formal fellowship programs, which are at least a year or 2 years long. But considering the current conditions in Pakistan, that would take maybe decades to establish the subspecialty. So do you think there is any alternate way of maybe reducing the time span, or maybe breaking it up into different slots, so that the training could be imparted and the subspecialty could be progressed further in a shorter span of time?
Thank you for the question. At the outset, I'll say that there are probably people that are sitting here that have more wisdom on this topic than I do as it relates to training young neurosurgeons. But that being said, to the point that Dr. Thompson made, the graduates of any neurosurgical training program like the one here have the foundations to do a lot of these things. It's just sort of an icing on the top that might not look like a multi-year fellowship just dedicated to neuro-oncology. But I don't think that it's a solution that's going to be, overnight. I respect the comment that you made about the fact that there's so few and this might take years and years, but I think that it probably will. And I think I could imagine where neuro-oncology trainees from Aga Khan then go work at one place, train another fellow, and now you have 2 and then 4 and then 8, and certainly that doesn't happen overnight, but that's kind of what happened in the United States 30 or 40 years ago as the field has subspecialized. So yeah.
Thank you, Dr. Michael. So Dr. Gilani, you have experience of working in a subspecialized environment in pathology, which is the neuropathology. And now you have joined AKU recently, and I'm aware that you would progress towards subspecialization in pathology as well. So what constraints do you feel there are when one shifts from a general practice towards a subspecialized practice? And maybe we can learn from your experience, because you have been practicing neuropathology as a career over there in the United States.
So the pathology practice in Pakistan is largely general, which means that the pathologist is going to see specimens from all over the body. If I were trained here, I would be looking at breast, prostate, colons, in addition to brain tumors. And so I think it's harder to achieve excellence if you're not seeing a lot of cases of the same type. If you are seeing cases in a subspecialized field, you're able to see all the common things and all the uncommon things, eventually, and that builds up your expertise. So I think in terms of things that we can fix, specialization or a move to subspecialization is something that we should do. I think in the absence of that, it's harder to keep yourself updated with all the literature and develop expertise.
Thank you, Dr. Gilani. So my next question would be from Dr. Reed or Dr. Bari. So a major hindrance when we start something new is to have the acceptance from the stakeholders. And a majority, almost all of the neurosurgeons here are practicing general neurosurgery. So how do you see it, that how we can convince them to focus focus their practice only for neuro-oncology, or they can facilitate others? How do you see it?
Well, I think there are a few things there. I mean, there's obviously a need to have neurosurgeons here and in other resource-limited countries do most things, and just the sheer volume. And the volume of brain tumors, I imagine, could easily sustain someone or a group of people in any sort of large center. But I think having an identity is important, as I'm thinking about it. There's something about just calling yourself, identifying yourself as a neurosurgical oncologist, broadly speaking. I think that once you have that, people, begin to think of you in that regard. At least that's the way it happened to me, in the States. And, maybe that's my best answer, just having an identity. Certainly there's a need.
Thank you, Dr. Bari.
Uh, in Pakistan, there are two situations. One is the government situation and public, and other is the private. In the government hospital, there are two lesser doctors. So until unless the government invest in human capital, they invest in human resource and bring in more people, then it would be very easy over there because there wouldn't be any competition. The numbers are huge. In a private setting, it's slightly difficult, but the people have developed it. Look at Athar, he has tried to move himself towards the neuro-oncology only, and other people have tried to move towards the spine. So this super speciality is going to come. And this is the need of the day in all the big places, in all the big universities. Super specialization are coming. And if you have to survive, you have to develop some forte, some interest, like you are trying to get. When I asked the resident and they are so bright, they say, sir, we have to develop our interest into this thing. Initially, you have to do everybody has to become a general neurosurgeon and then they evolve. But nowadays, with the volume is coming and everything, so you can decide before and whatever your interest is, and you start doing more patients, and once you become better in a private setting, people would just follow you. That is the only thing we can do it, but it's much easier to do it in the government setup because they can always say, like if you go into the easiest comparable situation is in England. If you have, there are 10 or 12 neurosurgeons and one of them, 2 or 3 of them decide themselves they would be only doing oncology, 2 would think they would only do pediatrics. Now, the great divide has come. The pediatrics has already moved pediatric neurosurgeons in our place. The pediatric hospital is becoming. So then there will be 2 pediatric neurosurgeons. Then the spine would move away. So, and now people are coming, oncology is coming and then functional would come. So all these things, the super specialization would come. You can't stop it, I believe. And if you have to survive in the next world, you have to develop some forte.
I'll just add that, I think that what I've seen happening in the States anyway is when you start measuring your outcomes, you realize and you see it in sharp relief that patients do better when they're treated at high volume centers by high volume surgeons. And there was a very controversial letter sent out by a guy who is a chair at one of the major programs in the States in Atlanta, in Emory. Dan Barrow sent a letter out probably 15 years ago, 20 years ago, to all the neurosurgeons in his state saying, and he's a vascular neurosurgeon, saying, if you are not clipping, 80 aneurysms a year, you have no business doing it. And it really made a lot of people very upset, and I thought, wow, that's, very controversial, but there's something to be said for that. And I think the data kind of shows that, here, so outcomes, measuring them also help drive that, I think. You don't want me doing spine, for example.
Definitely.
The same is true in England. They have stopped small centers like Preston and other centers doing complicated surgeries. So they have developed a catchment area. In those catchment areas, the smaller centers can only a small amount of work. All the complicated case would go to the bigger center like Birmingham, Manchester, Edinburgh, all these places. So the things you do more every day, your results would be better. Simple as this.
I have another idea. What if we have a collaboration between a public sector hospital and a private hospital, and we rotate our postgraduates or residents from a public sector hospital to a private sector, so we can learn from both. how to deal with these public sector patients and with all the facilities available there. And in a private setup like Akhan, the majority of the facilities are available. So when we will send our residents here, so they will develop a better understanding of this neuro-oncology, and they will be more interested in this field. And it will become easier for the resident to restrict to neuro-oncology. So that will be another idea.
Thank you, Dr. Ram. Dr. Bari, what are your thoughts on this?
It's always, we always welcome, we always have, as you know, in the residency program, we have 2 months of extramural. At least 1 month of extramural we want them to do in a public hospital, because the sheer number of the trauma, not the neuro-oncology, we want to see them. We have a lot of neuro-oncology here, but we have less trauma over here. So we always want that our residents should see more trauma. So it's a very welcome thing. We can send our we can send our students to you to see the trauma and other pathologies, and they can come and see the neuropathology, neuro-oncology, all that stuff.
And also I don't think so, okay, cyberknife PET scan are also available in Akhan. So residents can be distributed to those places as well. So they have a better understanding how these modalities can be used to treat patients.
Yeah, sure. Whenever they are there, they would look in. I think it's a great idea. But we are always happy to exchange programs.
Thank you, Dr. Bari, Dr. Ram. Before we conclude, Dr. Michael, my last question. You have worked in Sub-Sahara Africa. Did you see the concept of super specialty there, or were they doing, as a generally neurosurgery?
Yes, but not in neuro-oncology. So I saw subspecialty in pediatric neurosurgery. That there was a population where somewhere between 40 to 50% of the population is pediatric. And so there was a great need for subspecialized pediatric neurosurgical care. So yes, and that there's, in terms of, you're talking about outcomes, we could definitely see and demonstrate better outcomes in kids that have pediatric neurosurgical conditions, especially things like hydrocephalus and spina bifida, but also posterior fossa tumors in those surgeons, those 2 or 3 surgeons that were just pediatric specialized than their kind of more general counterparts.
Thank you. Due to paucity of time, we would not be taking any questions from the audience for our panelists. And I would like to thank all our panelists for their pertinent comments on all these points. And we hope the audience would have got significant amount of clearance with regards to these challenges which we face over here with regards to developing of surgical neuro-oncology as a subspecialty in our country and in general in an LMIC setup. So thank you, everyone. And we